Good morning, or good afternoon, or good evening, depending upon your time zone. I'm Larry Gostin. I'm professor of global health law at Georgetown University and the faculty director of the O'Neill Institute for National and Global Health Law. And together with my co-teacher, Professor Crowley, we'd like to welcome you to the final session of the O'Neill Institute Colloquium on National and Global Health Law. We have truly a remarkable panel and probably the most important topic facing the world today, because it's become increasingly clear, certainly in the United States, but absolutely most regions of the world, that we're unable to stem this virus without strong therapeutic countermeasures. We don't have curative or even dramatically good treatments, but we do have a number of vaccine candidates that are highly promising. Just today, the United Kingdom has given emergency authorization for a Pfizer BioNTech vaccine. Then just yesterday, the CDC's Advisory Committee on Immunization Practices met to decide on recommendations to the states for priorities in dealing with the vaccine. The priority setting raises enormously important ethical and legal questions, not least of which is because we have health workers, nursing home residents, and others under extraordinary risk, but also have grave injustices that COVID-19 has amplified. For example, 4 times the number of Black Americans having COVID hospitalizations and deaths than non-Hispanic whites, for example. So the ethical stakes for vaccine priority and distribution are enormous. And then there are the logistical obstacles to distributing, particularly the vaccines that are being considered in the United States, for example, not just the Pfizer vaccine, but a Moderna vaccine, both of which are 2-dose vaccines, which makes it extraordinarily a difficult challenge. And as the Pfizer vaccine requires subarctic freezing technologies that are really not available in many parts of the world, and including parts of the United States. And so the stakes for the US are simply enormous for our economy, our health, our safety, the so-called getting back to normal. Globally, the situation is even much worse. We've seen vaccine nationalism with the United States, Canada, the European Union, UK, making advanced purchases. In the midst of this, we've seen heroic efforts from the WHO and its COVAX facility, and Seth Berkley is a key partner with the Gavi Alliance in COVAX, and it's such an honor to have him here to kind of talk about the importance of global equity and getting this to low and middle income countries throughout the world, and what WHO, Gavi, and CEPI can do with our partners to try to bring this epidemic under control. It's very unlikely that we're going to see a quick turnaround to the pandemic. And certainly even in high-income countries, not till probably the end of 2021 will we be lifting ourselves back to normal. And it remains to be seen how long the rest of the world will take. But it will be very telling, not only for global security, but for equity and ethics, extraordinarily important. And so with that, I would like to introduce Alex Phelan, who is going to moderate this panel. And she will have the honor of introducing our esteemed panelists. I have the honor of introducing Alex. She's near and dear to me, not only because she is, one of the great future leaders in global health law, that we will pass the baton to her. But also, she was my PhD student at Georgetown Law, and she's a remarkable scholar and advocate, a member of the Center for Global Health Science and Security, an assistant professor in the Department of Microbiology and Immunology at Georgetown University. She also has an adjunct professor appointment at Georgetown University Law Center. She works specifically in infectious disease and security with a focus on reemerging novel outbreaks and international law, including virus sharing. She has vast experience with WHO, Gavi, the bank, and other international institutions. So thank you so much, Alex, for leading this session. I will turn it over to you with great thanks to you and our panelists. And Professor Crowley and I will come back at the end of the session and give our reflections before we turn it over to our students. Thank you.
Thank you so much, Professor Gostin and Professor Crowley, for hosting today. As Professor Gostin noted, we opened today with the United Kingdom having granted approval for the use of the Pfizer-BioNTech vaccine, with more than 800,000 doses on their way to the UK from Belgium. The UK government has advised distribution will begin next week, with elderly persons in care homes and care home staff prioritised before older individuals more broadly and healthcare workers. As a small snapshot of what may be to come here in the United States, distribution will be from hospitals, medical clinics, and soon to be set up vaccination centres, all requiring sufficient physical and temporal proximity to ultra-cold freezers, in addition to the normal challenges of ensuring an unbroken cold chain. This is the first vaccine approved using mRNA technology, with emergency use approval being sought here in the US for this vaccine and Moderna's mRNA vaccine. Both announced phase 3 trial data of 95% and 94.5% efficacy, respectively. However, the publicly stated manufacturing supply capacity of these vaccines for the next year have already been contractually committed under advanced purchase agreements with nations around the world. In Pfizer's case, agreements are currently only high-income and upper-middle-income countries, and in Moderna's case, only with high-income countries. Wealthy countries have used law and its prioritization of private property rights, physically and with intellectual property, to secure this novel technology. And neither as yet have public advanced purchase agreements with COVAX, led by Gavi, CEPI, and the WHO, the vaccine pillar of WHO's Access to COVID Tools Accelerator, which seeks to ensure equitable global access to COVID-19 vaccines. However, these mRNA vaccines are not the only vaccine candidates out there. In total, there are 7 vaccines approved for early or limited use, and another 13 in large-scale phase 3 trials, and an additional 58 in early stages of clinical trials. One of these, the AstraZeneca Oxford vaccine candidate, uses established vaccine technology with initial phase 3 data showing 90% efficacy in certain cases, and was the first manufacturer to enter an agreement with COVAX for global distribution for equitable access to COVID-19 vaccines globally. In 1 year, we have seen incredible achievement: the detection of a novel pathogen, its spread globally, and the development of vaccines in response. But we've also seen incalculable tragedy and inequality. How do we ensure efficacy in trials is replicated to effectiveness in the real world? We have 2 parallel matters of distributive justice between countries and within countries. How do we ensure that the distribution of COVID vaccines doesn't compound inequalities that existed prior to and have been exacerbated by this pandemic? To answer these and other questions, we are deeply fortunate to be joined by leaders in this field, Dr. Seth Berkley and Professor Gregg Gonsalves. Dr. Hamburg sends her sincere apologies that she's unable to attend. We will very much miss her contributions, but as she's noted, we're in very good hands with Seth and Gregg, who I will introduce each in turn as they present today. We will follow up with a discussion with the class, and if you could please add any questions you have to the Zoom chat. And so to get us started, Seth Berkley is an American medical epidemiologist by training. Since 2011, he has served as the CEO of the Gavi Alliance and is a global advocate of the power of vaccines. During his time at Gavi, his focus has been to use his experience as an epidemiologist and expert in vaccine development to lead Gavi in its mission to improve access to new and underused vaccines and improve coverage and equity in poor countries. His work has supported the vaccination of hundreds of millions of children in the poorest countries around the world, preventing many millions of deaths. He is also the founder and former president and CEO of the International AIDS Vaccine Initiative. Seth has been featured on the cover of Newsweek and recognized by Wired magazine as among the Wired 25, a salute to dreamers, inventors, mavericks, and leaders, as well as by Time magazine as one of the 100 most influential people in the world in 2009. In 2010, Fortune magazine named Seth as one of its Global Forum visionaries, and we're incredibly honored to have him here today. Thank you very much, Seth.
Thank you, Alex and Larry and everybody. It's really great to be here, and particularly for the students. And so what I plan to do is talk a little bit about the COVAX facility, try to put some of this in perspective, and then I want to specifically delve into some of the specific legal and governance and regulatory issues that we've had to deal with. So first of all, you heard the history of Gavi. Our role in general is to try to have vaccines available for low and lower middle income countries. And, over the last 20 years, we've introduced 496 new vaccines in those countries, have lifted up coverage overall, and have worked to be able to drive prices down so that these vaccines can be taken up by the countries, paying fully for them as they get wealthier. So that's kind of the Gavi model. And the last time we worked on something like this, it was Ebola, and that'll play in and be very important as we talk about some of the vaccine-related issues. But as soon as we saw that this new epidemic started and that it was caused by a virus and that vaccines might be the solution, we then went and thought about the idea of creating a program for low and lower middle income countries. But the experience in 2009 with swine flu, where all of the vaccine doses for the world were bought up by a small number of wealthy countries, made us say that actually the most efficient thing to do, as we saw this was a global pandemic, was to try to create a facility that would be available for anybody at any income level. And so was born the COVAX facility. As you heard, it's part of the ACT Accelerator. We work with CEPI, who started in January working on vaccines. Their specialty is in R&D. We do the procurement and work on organizing delivery, and WHO does the work on normative functions and allocative mechanisms and the policy work and regulatory work. So in essence, each of the groups has their own skill sets they bring to the table. The principle of the ACT Accelerator, since it was emergency, was not to set up a new governance mechanism. So at the end, the decision was made that Gavi would be the legal entity for the COVAX facility. And that has been a challenge for us to set up a mechanism that can work across these countries. So what was the purpose of this? The purpose of this was to try to encourage countries to buy as a buying consortium, to work together to try to do this. And there are many benefits of that in a pandemic. It would mean that there's no competition between different countries for prices. It means that the supplies can be used for the best vaccines rather than spread out across the many, many candidates that Alex talked about, where you might have a situation where some of the less promising candidates might end up having access to resources and the most promising not. And it also means that if candidates didn't look as promising, you could use the manufacturing facilities and others and shift those over to more promising ones. So that's kind of the principles behind it. We set it up as the following. We had the overall facility, which, as I said, is for all countries, 92 low and lower middle income countries, as well as some small economies that were World Bank IDA eligible. And that's the 92. They are part of an advanced market commitment The idea there was taken from work we had done previously with the pneumococcal vaccine to create a mechanism to be able to encourage manufacturers to engage with us, and also from the advanced purchase commitment we used for Ebola. And then the other side was the fully self-financing countries. And the question was, would there be interest? Would there be interest in a time of nationalism, in a time with people withdrawing, to deal with their own populations? And to our great pleasure, 97 countries signed up. So we have 189 countries that are engaged with the facility. That makes up about 90% of the world's population. And this required new mechanisms of working. As I said, not new governance mechanisms, but we ended up having to create a way for the AMC countries to come together. That's larger than the number of countries Gavi normally deals with, because we haven't dealt with those small economies, and there are some other countries in there that haven't worked with us before. And then for the self-financing countries, we needed to create a new mechanism for them to have voice and to be able to be engaged on this. So that has been an important part of what we've done. In terms of just saying something about the portfolio, when we started, of course, there was no, we didn't know whether any of these vaccines were going to work. And of course, the way to maximize the chance of success, and by the way, the a priori success of vaccines, is about 7% preclinically and about 20% clinically. So you would have imagined that most of the vaccines would fail, was to have a very large portfolio. So working with CEPI, working with the Gates Foundation, but also outside of those institutions, we're open to any vaccines anywhere to try to create a balanced portfolio that would be available for the countries. And so, with that, we have a whole range of vaccines that have potential to be brought forth. And many of them, of course, are going to be a little later than now, but have characteristics that make them particularly interesting, like single-dose vaccines, vaccines that may be able to produce at higher yields and more inexpensively. And so it's important to make sure we continue to move forward on that. So that's a little bit about the facility, about what we tried to do. The goal was to try to come up with 2 billion doses. Where did that number come from? We thought that was the number of doses that could be produced in a year. Obviously, if the yield is good, it could be more. And what's interesting about it is, what to do with that. There was a study done by Northeastern that showed if you took those 2 billion doses and you only distributed it to the 50 high-income countries, you would get rid of about 30% of the deaths. But if you distributed it equitably across the world, you would get rid of more than 60% of the deaths. And this is important because in a global pandemic, you're only safe if everyone's safe. And so the goal here is to try to tamp down the epidemic globally by starting with healthcare workers, moving into high-risk groups around the world, and making sure everybody has access to vaccines. And so, it's a different philosophy, but I think when we're talking about a pandemic, that's the way we have to think about it. Now, just pivoting over to some of the challenges we've had. So we have a very small legal team at Gavi, but we had to jump over and a lot of work on contract law, on trying to get legal agreements for governments where they would transfer money to us. We had to deal with different sovereign risks in different countries, from non-rated countries, fragile countries, up to AAA rated high-income countries. We then had to begin to think about a whole range of other things. And this gets back to epidemics. So one general point, and I'll stop in a minute, but one general point is that, when there is an epidemic, everybody is focused on it and it's the highest priority. But I can tell you that when Ebola was happening, people said it's the epidemic, it's the epidemic of the decade. This is, the most important thing. Money should not be the object. I can tell you a year after, when I was going around trying to raise money for Ebola vaccines, people were like, oh, that's yesterday's problem. We're not going to think about that anymore. So maybe the silver lining here is that people now will understand how important, infectious diseases can be. But the reason it's important to say that, there were many things we tried to do for Ebola, but didn't succeed. So a few examples, and if Peggy was here, she'd talk about this. Regulatory harmonization. How do we, in a pandemic situation, get vaccines out to everybody? And, some countries have stringent regulatory authorities, but many don't. And we use WHO pre-qualification, but how do we get that accepted everywhere and have the type of regulations that allowing that? Simple things like labeling. How do we label the products? Can we have one label for the whole world, or do we need labels for every single country, every location? And that, again, is an important issue in getting agreement on that, given it's a sovereign issue. Indemnification and liability are a really big problem. These are new vaccines, novel technologies, some of them, and the companies can't get insurance, and they feel they need to be indemnified, but not every country has that in place. They also need mechanisms to deal with liability. And of course, if there are side effects from vaccines in countries that don't have strong health systems, how do we fairly make sure that there's no fault compensation schemes or other things that are needing to be done? So at the same time, we're sprinting on, the vaccines, on purchase, on building systems, we're trying to solve these problems. Last thing I'll say is the delivery issue. This is going to be the most rapid scale up of vaccines in history. We've done some really fast ones before. We did an activated polio vaccine in 73 countries over the course of about 18 months, but this is going to be the biggest. And what we need are bespoke plans, because we need to know what the risk groups are in different countries. We need to know how their cold chain is, how their supply chain is, what gaps they have, what type of technical assistance. So we've put $150 million of core funds into this. We're working with WHO, UNICEF, the World Bank, all of our partners, civil society, to try to get that information together so we can begin to provide technical assistance, strengthen cold chain, et cetera. You mentioned ultra cold chain. There's only one vaccine that requires ultra cold chain. People say it's impossible. It is not impossible. We delivered Ebola vaccine at -80 in DRC in a war zone. It is not easy. It is expensive, but it is doable. And it does raise, to your point of ethical issues, do we say, well, it's because it's difficult, we shouldn't make it available, or is it the goal that we try to make these products available globally? So these are some of the issues we're dealing with. I've already spoken too long. I'll stop, but I'm obviously happy to answer questions or go on top of any of these issues, all of which, could be a seminar in their own.
Absolutely. Thank you so much, Seth. That's a wonderful landscape of Gavi's work and the challenges. And thank you for focusing on some of the legal and regulatory issues that I'm sure we will dive into more in the questions. It's now my pleasure to introduce Professor Gregg Gonsalves. Gregg is a leading HIV/AIDS activist. He is a professor in epidemiology of microbial diseases, as well as an associate professor of law and research scholar in law at Yale Law School. He co-directs the Yale School of Public Health Global Health Justice Partnership and Collaboration for Research Integrity and Transparency. His research focuses on the use of quantitative models for improving the response to epidemic diseases. For more than 30 years, he worked on HIV/AIDS and other global health issues with several organisations, including the AIDS Coalition to Unleash Power, the Treatment Action Group, Gay Men's Health Crisis, and the AIDS and Rights Alliance for Southern Africa. He was also a fellow at the Open Society Foundations and in the Department of Global Health and Social Medicine at Harvard Medical School from 2011 to 2012. Professor Gonsalves, thank you so much for joining us today.
Thanks, Alex. So it feels like an old home week seeing Seth here and Larry here, and it's really wonderful actually to be with all of you. And what I'm about to say is harkens back to sort of my career in HIV. I've been interested in two things over the course of 30 years, which has been access and answers. These themes are going to come up in the context of what I want to talk about around COVID-19 vaccines. As you said, we've been working on a project here called the Collaboration for Research Integrity and Transparency. And much of that has been about the conduct of clinical trials and availability of data. And we've been doing this for several years now, and it's all been in the context of therapeutics. And when you think of the history of biomedical R&D on the therapeutic side, you have Avastin, you have Vioxx, you have other drugs, which, after they've been approved, turn out to be dangerous or ineffective, and our contention is that the regulatory structure failed us in terms of protecting us from safe and ineffective drugs. In the context of COVID-19 vaccines, a group of us became sort of alarmed in I'd say the late summer of this year, about the press from the White House for rapid approval of vaccines, about this October surprise that was all over the newspapers and the medical journals in the late summer, early fall. And a group of us were trying to think about how do we ensure that the vaccines that get approved when they do, and that's coming very soon, are held up to the highest standard of scrutiny. And one of the things we thought was that we need to think about transparency at different points in the life cycle of vaccine development. And we sent a letter to Secretary Azar earlier this fall, talking about getting access to the protocols for all the trials that were funded with US government support, appealing to all the CEOs of these companies for the clinical trial protocols as well, all versions, all amendments for each phase of clinical trials in all countries. Lots of the companies have been fairly forthcoming about their clinical trial protocols, and we commended them in our discussions with the Trump administration, with the companies. But we also think that if you're going to get a good picture of what's going on under the hood in clinical trial development, you need to know about their statistical analysis plans. Again, amendments for all ongoing completed vaccine trials. You know, we need to know the stopping rules, the Data and Safety Monitoring Board charters for all the trials. We wanted to see case report forms for all the trials, consent forms for all the trials, minutes of the IRBs, clinical trial agreements with the NIH and any other relevant government agencies. This is in the context of broad suspicion that the Trump administration was going to interfere with the approval of these vaccines. And we've seen over the past 48 hours, President Trump is wondering why we're not pushing faster ahead for approval and putting pressure on the FDA even in the waning days of his administration. So those are the sort of questions we had earlier this fall for Secretary Azar and for the vaccine CEOs. I think in the context of the imminent EUAs that are going to come through the FDA over the next few weeks, is that we need to be able to get companies to share data from all their studies in a format that allows for secondary analyses by independent researchers. And there are templates for this. At Yale, we have something called the Yale Open Data Initiative, Yale Open Data Access Initiative, YODA, that Harlan Krumholz and Joe Ross here have put together. But there are other sort of data repositories around the world and around the country that would allow companies to put their patient-level data sets in a repository for secondary analyses. And considering the quick approval we're going to see of all these vaccines, the limited time scope for those trials, it's going to be very, very important that data transparency is part of the life cycle of development of these immunogens. So that's a sort of the answers piece. You know, as Seth said, we're doing this at lightning speed. Approvals are happening quickly. These vaccines are going to go into billions and billions of people. We need to have sort of maximum transparency and maximum sunshine on these vaccines, so we know what's going on and we can have independent analyses. The second thing I'd like to pivot to is about access. And I think Seth has talked a lot about the global access challenges. I think Alex, you've reflected on it too as well, about certain countries sort of buying up the available supply of vaccines. But I want to talk about the United States for a second. Larry and Michelle Williams and Harold Schmidt wrote a piece, I think in JAMA, about whether it's legal to allocate vaccines on the basis of racial disparities in the United States, suggesting that probably under the current environment in the Supreme Court, that any sort of race-based classification for allocation might be frowned upon and get struck down by the highest court in the land. I think the National Academies of Sciences and their rubric for vaccine allocation has the sort of framework around age-based allocation, profession-based or occupational-based classifications, but they also said we should think about SVI, the Social Vulnerability Index of the CDC, as another way to allocate vaccines. And I'm going to see if I can share my screen with you. Can you see? So we've been working on a project with the Center for Spatial Research at Columbia's Architecture School. And, you know, we've been thinking about vulnerability in the context of the epidemic. And I just wanted to get us to think about what vulnerability means in the United States. And this isn't just for risk of COVID acquisition and transmission, but it also speaks to some of the logistic challenges that Seth and Alex have spoken about. Many of the places that I'm going to show you right now are going to have questions. The people in these places are at a distinct disadvantage from a health perspective, but the infrastructure in these places also makes it a challenge to deliver vaccines and other interventions to them as well. And so we put together this map of the United States, which you can go to. I'll send a link out. It's called the newpoliticsofcare.net, so you can go look. But we wanted to think about, how do you think about vulnerability in the context of the COVID pandemic? And here is the map of the United States, but I'll just show you one case study, which is Arizona. If you look at SBI in Arizona, if you wanted to think about where you would go to target vaccination campaigns, you'd probably do it at two different corners of the state, Numa County and Apache County in the state. Apache County and Navajo County to its left, Native American reservations, high levels of social vulnerability. But as Larry and Michelle said in their piece, it could very easily be struck down by the Supreme Court if we tried to allocate vaccines by SBI. You could do it by years of potential life lost. You start to move around in terms of what this means. Yuma County disappears from sort of the highest years of potential life loss if you're trying to define vulnerability in that way. You can think about it as Medicaid enrollment as another way to think about vulnerability. Again, Navajo County is going to has the highest in the state in terms of total estimated Medicaid enrollment. Might be another place to target vaccination. Or you could look at something such as unemployment as well. This is just giving you a sense of what goes on across the United States in sort of the geography of vulnerability that we need to think about. COVID isn't a great example of ways to think about vulnerability over the long term. None of the historically vulnerable places in Arizona had the highest rates of COVID-19. Maricopa County with Phoenix had the highest rates of COVID cases over 14 days in the state. And in terms of the density of COVID, it was Gillett County next door. I think what to say here is that when you look at a map of the United States, vulnerability described in many different ways is going to play out differently depending on how you define it. And we're going to have to figure out how to deal with it in the context of vaccine deployment, because it's not just about people under 65 or healthcare workers, because the barriers in Navajo County and Apache County in Arizona versus Maricopa County or Utica County are going to be very different. And the needs expressed are also going to be different. And so I don't know how we're going to have this conversation, but the sort of rubric of healthcare workers or nursing home residents gets you to one level of need in the United States in terms of who needs to be first in line for vaccines. But the pandemic has followed these other fractures and inequalities in the history and the geography of the United States. And unless we deal with these larger vulnerabilities, we're going to.
Greg, what we might do, we seem to have lost you. What we might do is
I'll send them an email, and maybe you should just carry on with the session, good. And we can always bring them back.
Absolutely. Thank you very much. So that was incredible. It's wonderful to see that data and see the analysis up straight away. And what I might do is, if we can move into the questions, we have some wonderful questions from the students in the chat here to get us started. And the first one actually quite nicely picks up on one of the points that you made, Seth, about regulatory harmonization. And Caitlin Curry asks whether regulatory harmonization, do you believe it's actually feasible for COVID-19 vaccine distribution? And if it is feasible, could it be extended to other vaccines or therapeutics now or into the future, rather than to say once off? And one of the parallel examples Caitlin gives is biosimilars with FDA, EU contemplating harmonization. You know, I think there's another angle here that, you know, would be interesting to touch on potentially, which is the role of broader geopolitics in accepting regulatory harmonization and worries about political pressure. We've, you know, seen today the EU come out, the European Medical stating that they're concerned about the speed at which the UK has approached this approval today. So a very large question to you, Seth, but you know, do you think that harmonization is feasible and can it be extended normatively beyond COVID?
Thanks. So before I answer that question, I just want to make a comment because I thought the mapping that Gregg put up was really fabulous. And for, my countries, not my countries, but the countries I'm working with, particularly the low and lower middle income countries, the first issue is, are we going to have vaccine at all? And then the issue is, can we get it out to some of the highest risk groups? And then you get into the detail of the questions that we're hearing. And that's what I meant by the bespoke plans, because you need to give people a chance to do that. But we got to start at equity at the highest level, which is, there is a risk that we're going to see all of these people lined up getting vaccinated in the UK and the US and other places without vaccine in the developing world. And that's the first thing we're trying to solve, because we believe, as I said, it has to be a global response. So getting into that question, I think the challenge is that nation states pride themselves in sovereignty and national sovereignty, and yet they understand that working together as a group is important. And so we've seen experiments like the EC occur where they have an EMA, but also a number of the European states have their own regulatory systems that they also use. And so then they allow either one or the other. We have other gatherings that traditionally have come together, but have not made the step to leap all the way into harmonization. It would really make a difference. Now, the African Union, for example, is now working towards a harmonized regulatory system, but up until now, it hasn't been accepted by all the states. And so what that means is that theoretically, each state wants individually, their own data packs, their own ability to review, et cetera. And of course, at a rapid movement, when you've got and trying to get vaccines out to 200 countries, you can imagine that that's going to slow things down, particularly if there's questions and people need to be engaged. So I do believe that at this moment, we may get to a situation where large numbers of countries will accept at least regional harmonization. And in an ideal world, maybe WHO pre-qualification built on top of a stringent regulatory authority. And if that happened, then it would allow these to move as quickly as possible. And we'll have a chance to test this because, if there are early vaccines, the question is will countries want those? And if so, how are they going to have to do the regulatory aspects? Of course, to your question on safety, that is a really big problem. There are a number of vaccines that were referred to. I think Larry referred to them. I think we talked about, 7 vaccines that, have been out and that have, results. Some of the vaccines that are being used now do not have efficacy results. They started getting distributed in phase 1 without adequate, one of them had 70 people enrolled in a trial, and then they were just vaccinating general population. No efficacy, no long safety, no subgroup safety, none of that information. So there is no question in this political environment, things are moving quickly. So I think we have to balance speed, but the most important thing for vaccines is safety, because at the end of the day, you do give it to healthy people, you give it to billions of people. And, we need to have very large trials to look at safety, adequate time to follow it up. And then we need pharmacovigilance that follows that up to make sure there's not rare side effects you're missing. And all of that is being worked on now, but it's, it's complicated.
I think that ties in nicely to the points that you also made about Gavi's approach to creating an indemnification and liability scheme, particularly as the emergency use authorizations manufacturers typically require or want some form of indemnification from liability, and that in of itself is a kind of legal injustice that exists globally, that some countries have the capacity to be able to offer that, but also at the same time ensuring that where there are perhaps adverse events or side effects or other errors in the process that could actually mean that people don't get access to justice if they do. I mean, do you mind sharing a little bit of the thoughts around that process? I mean, it was a fairly novel thing for Gavi to be doing, is to be stepping into this realm, but really critical from an equity and justice point of view.
Well, first of all, if there are faculty members or students who ultimately want to work on this stuff, you're welcome. As I said, we have a small team and we've been trying to get volunteers and people to come help us on all of these quite complex issues. we fundamentally believe that, these systems should be in place everywhere, and they need to be, they need to be gated. This is not about giving companies a free ride. There needs to be systems built into it. If they're not following good manufacturing practices, if there's, gross negligence, other factors need to be in there. So there should still be liability for manufacturers. But, the point here is they're moving quickly, trying to make these available widely. And how do you deal with that? So, one way is to try to have some type of indemnification. And then the question is that strong enough? Do we need some guarantee behind that, particularly for financially weak countries? But the second part is having something like this no-fault compensation scheme. And that's a really interesting issue, because that's a good thing. If you get sick from a vaccine in the UK, you got the National Health Service. If you get sick in most countries, most wealthy countries, you have health care that's available, national health systems. You don't have that in many very poor countries. So people are kind of on their own. So if you had no-fault compensation schemes, that would be fair. It would also help on the indemnification issues. And one of the interesting things, though, is one manufacturer, who I will not name, said, no, we're not going to give our vaccine to anywhere that doesn't have a no-fault compensation scheme. So it may be that we can put that in place easily for developing countries because they don't have anything, but it may be some of the upper middle income countries that'll be neither here nor there. They won't have the indemnification, they won't have time to put legislation in place, but they don't have a no-fault compensation scheme. So these are the types of things we're trying to struggle with in trying to be both equitable and have justice in what we do, but also to try to practically make sure there can be access.
Thank you so much. I noticed that we have Gregg back on the line. Gregg, as we lost you, I said that we also had the data that you were presenting was fascinating, and I wanted to give you an opportunity if there were any sort of concluding points or other points you wanted to make before we lost you. Oh, we may have, unfortunately, it may have happened again. I will have that as a standing invite. If Gregg, you get connection back, feel free to jump in and interrupt, because I want to hear much more of your thoughts. So I'll continue on, and this is a practical question from Patrick O'Neill here in the chat. We have lots of different vaccines. A number of them require 2 doses. In some places, people may end up getting access to more than one vaccine. How are we practically going to ensure that people are able to get the second dose of the same vaccine? There is some talk of using electronic health records, which will be, infrastructure dependent. But how do we, how are some of those challenges being thought of? Is it based on geographic restrictions, so there isn't the chance that someone could accidentally get a different vaccine? How do we deal with follow-up as well as potentially different vaccines?
So it's a really great question, and it's not fully worked out. And just to give you an example for the non-technical people, you can go to Whole Foods and buy a banana, and we can trace that back to which tree it was grown on, in terms of how the food chain is. That's not true in most of the medicines in developing countries. And we had just started before this. I had done a TED challenge on how you track and trace vaccines, and just now barcoding is becoming a normative function on vaccines, which is kind of in time for this, but the systems aren't well set up. Now, we've had many experiments on this, and one of the silver linings here could be if we set up a system that allowed people to be easily tracked. But the truth is, it won't be done. A lot of it will still have to be done by paper and follow-up, which is not ideal. There will be geographic and large countries where you may spread it out, but then you're also going to see it's going to be spread by the risk group. So, for example, if you're doing mRNAs, you may use those for health workers in teaching hospitals, intensive care units, places where they have the highest exposure because maybe they come first, and then you may have other vaccines following that will be in the same geographic area. So it's going to be very important to keep that clear. The last thing that's going to happen is people are going to start doing heterologous studies with the different vaccines to know both safety, but also the boosting ability. For many of the vaccines, it may be that boosting with a different vaccine vaccine may actually give you a better immune response. And so, these are all the questions that are there when you have this fast moving science, but it's going to be a problem.
Thanks.
And ideally, by the way, a single dose vaccine is better than a 2-dose vaccine. And so I think that's the other thing that, will be coming soon. We'll have some candidates that potentially are single dose, but again, we don't know until we get efficacy results.
Thank you. I think I can see Gregg's back on.
I'm hoping
Yes, yeah.
Hi, sorry all. It's just, I have no idea what's going on. This hasn't happened before.
So welcome very much, Gregg. If you had any additional concluding remarks on what you were talking about with the mapping, or any sort of other concluding comments before I turn some questions to you.
No, I mean, I think I was going to say that, Larry's article with Michelle, we're going to look at the area deprivation index and try to think of some other ways to think about how you might allocate vaccines based on sort of other kinds of disparities that could track with the ones we actually see epidemiologically that might be in the taste of the Supreme Court as it now stands. So, yeah.
I wonder if I can sort of push back on that and throw a question to you on that. Is there a potential risk or a normative risk in using indirect measurements rather than just racism? Is by trying to use indirect measures of racism, are we potentially undermining the importance of addressing that as a cause of COVID-19 disparities, just from a normative point of view?
Well, the reason we did this Mapping the New Politics of Care project with Columbia's architecture school is because Amy Kapinski at the law school and I put together some pieces for the Boston Review about the genesis of the COVID-19 epidemic. And it's sort of historical. And we think about the deep sort of development of the American healthcare system, the public health infrastructure in the context of our own sort of history of slavery and white supremacy. And so, yes, we should allocate based on much more direct measures. But as the lawyers in the room will know, that race-based classifications are not going to hold up in the Supreme Court. So we want to do the best with what we can in terms of the kinds of classification schemes we have that will hold up to strict scrutiny. But I agree, we should, to be blunt, racism got us into the nature of the pandemic that we have in the United States, and confronting it directly is going to get us out, but it's not the kind of nation we are at the current moment.
So, I mean, we've been talking a lot about the about equity and equity within countries, as Gregg has pointed out, but also equity among countries, as Seth has pointed out. So let's just dig a little bit deeper into both of those. Gregg, tell us what you think of the equity values that ACIP put forward yesterday, or lack thereof. And then I'm going to turn to Seth and ask a little bit about the consequences of inequitable global distribution.
As far as I heard yesterday, the ACIP recommendations were based on nursing homes and then an age classification. Is it true? I didn't see any other sort of equity considerations listed in the discussion.
Workers.
Healthcare workers, yeah.
Health workers, nursing home residents, but very little granularity in either of those, and then not a lot on equity and social disadvantage.
No, I mean, the nice thing about the National Academies report is that they did talk about SVI, but I don't understand why the people on that panel didn't understand, as you and Michelle talked about in your piece, that this was going to be subject to a contentious debate in the United States. And so, look, I mean, the reason we did the Mapping the Politics of Care project is that COVID follows the fractures in US sort of history with race and class, and that if we ignore it in the context of delivering vaccines, we're going to create a two-tiered recovery. We're going to have a bunch of people who are in rich states, rich counties, counties with larger infrastructures, and more robust public health infrastructures who are going to get out of this pandemic before others. And it's what got us into the mess in the first place. And so I don't understand why there's a desire to ignore equity. I do feel like the Biden transition people are thinking about equity in a much more concerted way. but we have to wait until January 20th to see what that means.
Yeah, and by then a lot of the vaccines will start to be distributed. No, I think you're exactly right, Greg. I mean, to me, you might capture some equitable distribution, say with essential workers, but I think factoring in things like housing density, unemployment, poverty, lack of education is really going to be important. But we've only got a little while left, and I want to turn to Seth, if I can, about the global side of this, because that really concerns me a lot. And the United States really has not been paying close attention to the global side. And as we know, the Trump administration hasn't joined the COVAX facility, although I hope that the Biden administration will do that early. And I'd love to hear your views on that. But if your imagination is right, Seth, and I think it is, that we'll see long lines for vaccines here in the US, UK, Europe, while people wait in lower income countries and wait and wait and wait. Well, I think all of us can understand how unconscionably unethical that is. But what implications might it have for the pandemic, and also what implications might it have just for global stability, security, and global cooperation around a whole range of global challenges that we face?
I think those are great questions. And first of all, I gave the example of modeling what would happen if you
did, and it was fantastic. I actually tweeted it already.
I saw that. But what I think is really interesting is you got to think of it. You're never going to have 100% of people vaccinated. You're never going to have 100% efficacious vaccine. So if you've got large reservoirs of people with virus circulating, it's going to put you at risk, and it's going to put commerce at risk, and trade and tourism. Today, we lose $500 billion in global GDP a month. And developing countries are hit the worst because, of course, they can't sit home in their, nice houses, on Zoom having these discussions. Many of them are working in situations where they're hand to mouth and informal economy, et cetera, and they have to get on with that. So I think the challenge is going to be, we're not going to get the economics back. Now, that's not the primary reason, to do it. I think we've learned now, if you don't have your health, you don't have anything. But the point is that, this is the first time poverty has increased in 20 years, global poverty. And we think another 130, 150 million people are going to be put into global poverty. So this is about tamping down the pandemic globally. And Gregg, when you were gone, I said how much I liked your mapping. And I said, this is the bespoke part of what we have to do. So, if here in the US, you're talking about nursing homes and maybe prisons and meatpacking plants and, whatever the subset is in the US, what does that look like in other countries? Is that refugee camps? Is that, is that urban slums? Is that, is it certain ethnic groups that are otherwise, treated poorly and stigmatized, et cetera? So we need to really think about that in every single country. And that's why the bespoke plans are so important, because the goal should be the same, to try to end the pandemic as soon as possible. And understanding that is going to be a challenge. Now, the one last thing I'd say that, the students may like or not like, we made a decision that at least for the first 20%, we would go out across all countries equally. So we looked at that as an equity principle. We didn't say we're going to try to pick which countries, are doing worse or which countries are more vulnerable or whatever, because we felt that was the fairest thing to do to start with. But then after 20%, the WHO allocation mechanism has an ability to then say, how do we now specifically target places that are more vulnerable or have more issues, for additional doses? And of course, that's all untested. This is new stuff that we're doing, but it's really important. And lastly, your point on the US, we miss the US. The US has been a driver of global health and, of course, a driver of science. And we're taking advantage of the science out of Operation Warp Speed. But we do look forward to the US re-engaging and helping, to move this stuff forward around the world.
Yeah, well, you'll be happy to know that just today we have an article in The Lancet with Donna Shalala and Jeff Copeland, Michelle, and Peggy Hamburg and others that on Biden's global health agenda, and COVAX comes right at the top of our recommendation list.
Thank you.
To join and to amply fund COVAX. I mean, it's just been, I just sit back in awe of what you, Tedros, Seppi, and others have done with COVAX. And I just, I worry that there's not going to be the funding and the supplies to do what we absolutely need to do as a world. Let me just end with, one wonky question to either you or Greg who want to answer this. But, as Alex began, with there's so many vaccines out there with so many different technologies. And you'd mentioned this earlier, Seth, in your conversations about, how do we know which ones work? Which ones will be deployed best in which populations in which parts of the world? Because, we could just have a mad scramble and, I suppose we could throw darts and we'd probably hit our target quite a lot. But should we be worried that there aren't these strong comparative evaluations going on about which vaccines for what groups, including, for pregnant women, children, other vulnerable populations who haven't been included?
Absolutely. But I mean, you have to realize where we are. First of all, blow us away. Normally it's 7 to 10 years for
vaccine. Yeah, I know, of course. Yeah.
AIDS vaccine. How many years have I been working on that? And we're not there yet. So 303 days from the time we had a genetic sequence till we had efficacy results in a large scale human trial. It's just unbelievable. But that means we still don't have full data in subgroups. We don't have data. I mean, luckily, the two trials the large trials that have been done one of them had very good a breakdown by race and very comparable to that in the US, and that's going to be very helpful in the full analysis of subgroups to get a sense of what this is. But you're absolutely right. Pregnant women, children, people with certain conditions, people immunosuppressed, et cetera, we're not there yet. I don't think that means we should stop right now. Obviously, we should be moving, but we need to make sure we get that data. And that is a big debate right now, whether you give placebos to you give vaccine to the placebo arm and don't finish the trials. And that's an important question. But then the other issue is there are characteristics. And, I mentioned single dose. Obviously, give me a choice between a -80 vaccine and a room stable vaccine or a 2 to 8 degree. I'd rather have the 2 to 8. So the challenge is going to be as we get the characteristics of the vaccine, and then there's going to be a trade-off. If I have a single dose that is 70% efficacious, is that better than a 2-dose that's 90% if you're using it in a campaign setting? And already people are beginning to think about that. Do we give the ultra cold chain in hospital settings, and then for doctors' offices and for out there, do we give the 2 to 8 degree? So I think it's going to be a combination of logistics and where it works best, et cetera. And it's not totally predictable. I mean, people are trying to predict it now because you do trials based on what you think, but I think we're going to have to see.
Yeah, well, I think we're going to probably have to leave it there. Let me just try to quickly sum up and invite Professor Crowley if he wants to as well. This has been just a remarkable panel. I mean, for me, who's been so involved in COVID, to see, as Seth said, vaccines coming to the fore, it's given my heart some hope for the first time in a long, long time. And it's the way I kind of think about this is that we're facing the two most awesome forces that we know of. In tension with each other. One is this tiny microscopic virus that controlled the entire planet within a matter of weeks and months. And the other is, human ingenuity in science. And, you've just got to step back and just, tip your hat to both of those, both Mother Nature and to scientific ingenuity. But now that, we do have great vaccines, it appears that way. And we're going to be getting stringent regulatory authorities approving these, at least in emergency and probably full approval before too long. We now face, the biggest challenge we faced in humankind, the logistics of getting it to everyone, the equity of making sure that no one is left behind, the SDG pledge that was so important, particularly in the global narrative of people being left behind and feeling that way, and that being amplified during COVID-19. And then Gregg's, brilliant mapping of social vulnerability and digging deep into ways that we can find just solutions to getting vaccines to everyone. And we need to do that in the United States, in Europe, and other high-income countries, but we absolutely have to think globally. And for that, to think that we've got public-private partnerships like Gavi and CEPI, or to think that we've got a World Health Organization with Tedros leading it, is very heartening. And I just hope the world gets behind those in vigorous ways. So, thank you so much. This has been a great panel. I know our students and our audience are going to, understand what a privilege it's been to listen to this. So with that, we'll say thank you very sincerely. Goodbye, and then we'll take a short break, and then we'll come back with our students to reflect further. So Jeff, when should we come back? In about 5 minutes?
Yeah, so we'll come back at 10 past.
Okay, great. Thanks, everyone.
Thanks to our panel. Thank you.
Thank you.
Thank you so much.
Oh, you're back, Alex.
Apologies. You had it well in hand, Larry, so thank you so much.
Larry, I think the most important thing is that this is not the last, and so woe on us for not being as prepared as we could have been now. But, if we don't learn from history, we're doomed to.
Oh my God, yeah, I know.
So this is your constant screaming, about that, and me being called a coronavirus Cassandra. I love that title, but how do we get people to listen? And Gregg has been talking about these things forever. Yeah,
and you mentioned H1N1. When we. What did we learn since then? Well, apparently a lot. We've got COVAX and the Social Vulnerability Index and people like Gregg and you. So, okay, well, thanks. Thanks, Alex, Gregg, Seth.
Thank you so much.
And
all right, bye, guys.
We'll be following up by email. Take care.
Okay, bye-bye.